This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
It's with great pleasure that I introduce a good friend, Andy van der Pol. Andy, as you'll see from his bio, originally comes from Zimbabwe and trained in South Africa. We were lucky to have him train in intensive care and anaesthesia in the great city of Auckland. And he went away to Brisbane for a time. And thankfully, like all good Kiwis, was sent back to New Zealand. And I'm delighted that he is a colleague in this city. He works at the Department of Critical Care Medicine, the DCCM, at Auckland City Hospital. And they are our local liver experts and liver transplant unit. And any of you that were at the party last night will know that plenty of people in this city get to exercise their livers on a reasonably regular basis. And although I know that boats and alcohol don't mix, last night they clearly did. But I'd like to introduce Andy to talk to us about when the livers are broken.
Good afternoon. Just to introduce myself, I'd like to say that I'm certainly not an expert in this field. I find looking after these patients very, very difficult and tricky, and I think my more experienced colleagues, as well as the hepatologists, probably dread when I'm on call and we get one of these patients. We, the Centre for Transplantation in New Zealand, and we do, well, since 1998 we've done over 600 transplants now, and only about 10% of these are for acute liver failure. Obviously not everyone who has acute liver failure gets a transplant, and as you can see, majority of ours are secondary to non-A or non-B or seronegative hepatitis, with quite a high proportion of hepatitis B. If you look at the data at the bottom there, that's Australia, New Zealand, and we disproportionately got a higher or relatively high incidence of hepatitis B infection. The hepatitis B can be as an acute infection, or more commonly now we're seeing a lot of flare-ups of people who are known to have hepatitis B. Other causes include drugs. Paracetamol is actually quite low, and New Zealand's, I think, quite similar to France and Japan in having a relatively low incidence in paracetamol toxicity. And worldwide, the higher countries have been America and UK, and these are dropping as well. Just to go through the definition, acute liver failure is acute onset of encephalopathy and coagulopathy, so liver dysfunction in someone who's not known to have a history of cirrhosis or liver dysfunction. So acute alcohol hepatitis is usually excluded because they've been drinking for a period of time. It's further subdivided into hyperacute, acute, and subacute, and that's really just on a time basis, but that also links to prognosis, with the hyperacute ones being a very much more dramatic presentation with higher levels of cerebral edema, but having a much better prognosis for surviving without transplantation. And then the prognosis worsens, particularly with the subacute group, who don't have as much cerebral edema but tend to have more renal failure and portal hypertension. The features, as most of you will know, I'll just run through them though, but include coagulopathy, which can be profound. And one of the rules of thumb, I'm told by the hepatologist, for paracetamol overdose is how severe the elevation of INR is according to a period of time. So if it's more than 2 at 24 hours, 3 at 36, etc., that's a significant liver injury. Encephalopathy grading is according to O'Grady, but basically ranges from mild confusion, hardly anything, to a comatose, unresponsive patient. And unsurprisingly, their cerebral edema is more common with a higher group, up to 75% of patients with grade 4 encephalopathy. And again, ones who have got higher encephalopathy tend to have a worse prognosis as well, in terms of spontaneous recovery without transplantation. Bilirubin is usually elevated. Transaminases can be profoundly elevated, particularly in drug toxicity. And when these levels come down, as I'm sure most of you are aware, it does not necessarily indicate recovery. It can just be that the cells are burnt out. Acute kidney injury is common, and also is associated with a worse prognosis when it occurs. Electrolyte disturbances, hyponatremia, hypoglycemia, hypokalemia, again, are all common. Hypophosphatemia as well, and that actually can be a positive prognosticating prognostic indicator in that as cells recover, they tend to take up more phosphate. Hyperlactatemia is again common, and in paracetamol overdose after fluid resuscitation, if lactate persists, is one of the indications for referral to transplantation. Ammonia is quite interesting. We all measure it. It's probably more useful in chronic liver failure, but certainly if it's measured early, it's a prognostic indicator. So people with high ammonia above 200 have got much higher incidence of cerebral edema and a worse prognosis. History and examination, sorry, these are quite busy slides, but basically try and get as much history as you can before the person becomes really encephalopathic. There you're looking for risk factors for viral transmission, drug use, things like ecstasy, intravenous drug use, recent things such as heart failure, or arrhythmias that may cause an ischemic hepatitis, and then social history. And if possible, we'll get them seen by one of the specialist psychiatrists if they are a transplant candidate, just to assess whether they will be able to cope with it from a social point of view. Examination will reveal the depth of encephalopathy, as well as some other useful things. They may have skin rashes, such as with herpes simplex virus infection. Blood tests, we send off loads of them. To me, probably the most important ones are just looking for things that are reversible. So viral studies, including herpes simplex virus, because you can treat these, autoimmune screens, paracetamol level, pregnancy tests, and then often these patients will get CT scans, but if they've got renal impairment, it's probably not necessary, and an ultrasound, particularly Doppler ultrasound, will be useful for excluding things like Budd-Chiari syndrome. I won't run through all the other tests. We usually measure ammonia anyway, but all the other standard tests, including coagulation and UENC. Biopsy is very rarely done these days. I've said usually it's pretty much almost always transjugular, and that's really to look for causes which we don't pick up from blood tests, things like Wilson's or autoimmune, and sometimes we'll pick up cancers, which would then probably exclude people from transplantation. The liver team, particularly here, are very, very good and very supportive. They like to hear from anyone who's concerned about their patient, particularly from outlying areas. But there are a number of red flags. If people are acidotic and this persists after resuscitation, really elevated INR that's not improving, hypoglycemia, encephalopathy, acute kidney injury, and then prolonged thrombocytopenia are all red flags, and they really would like to hear from people who have patients with these problems. In terms of our management, they can be very, very tricky and difficult patients to manage. Often you think about avoiding sodium-containing fluids, mainly because of cirrhotic patients. These patients are hypovolemic. They've often got very high insensible fluid losses. They haven't had much in the way of oral intake, so they need resuscitation, and they need salt-containing fluids, obviously not too much. We need to restrict free water because of the risk of cerebral edema. We aim for a MAP of above 70. Sometimes if there's acute kidney injury, we may even aim a little higher in the beginning. And they usually need vasoconstrictors after fluid resuscitation, and noradrenaline is a one of choice. There's some discussion in the literature regarding terlipressin. I don't think there are any definite answers. They are catabolic. They need feeding. This is not a cirrhotic patient where you're worried about protein load. They need food. They need about 1 gram per kilogram of protein a day. We tend to place nasogastric tubes if they can't take orally. If you're concerned about bleeding, orogastric tube if they're intubated and ventilated. Hypoglycemia is common, and we'll usually use high concentrated glucose running at a low rate in order not to give too much water. Ideally, don't correct the INR, so avoid plasma just because of its significant for prognosis. Everyone ran short, so I need a little bit of extra time. I'll just speak quickly. We don't use lactulose, rifamycin, Lola. These are debatable with subacute liver failures, but with acute liver failure, there's cell death. There's a huge overwhelming load of ammonia and other chemicals that cause the encephalopathy, and if anything, all that's going to happen is lactulose will blow up the gut, may cause aspiration if they're not intubated, and actually interfere with transplantation if they're very distended. Prophylactic antibiotics are used in some centers. We don't. We do screen, and we will start them with a low threshold. And again, these people have got huge outputs. They're often hypermetabolic, so it can be quite difficult. There's no evidence of improved outcome. One of the hepatologists said patients should be intubated when they show you their backside. Basically, we do that if they're agitated, if they've got rapidly progressive encephalopathy, or a very high-grade encephalopathy. And we use short-acting drugs, so propofol, fentanyl. Renal replacement therapy, again, start early if acute kidney injury isn't improving, and we'll often add 4 molar salt to the bags, aiming for a sodium of around 150 to try and keep them slightly hyperosmotic. We'll treat the treatable causes, so things like hepatitis B, herpes simplex virus, we'll get antiviral medications. Budd-Chiari may end up with a TIPS procedure. And then paracetamol overdose, even when they present really late, we'll get N-acetylcysteine. Is it useful in all comers? Probably. I don't think there's good evidence. There's one paper from the States that showed people with low-grade encephalopathy from non-paracetamol-related liver failure may benefit from the use of it, and it doesn't seem to be any harm. ICP monitoring, I'm nearly done. It's controversial. 50% of centers in the States do it. There are a number of different types of monitors. We use intraparenchymal ones because they're more accurate, but there is a concern about bleeding. The reason we do it is because we can monitor the ICP, and we don't transplant people who've got severe cerebral edema or who have gone brain dead that are unable to examine. The risk of bleeding in the international literature is about 10%. We treat everyone with plasma, aiming for an INR less than 1.5, platelets, and we give everyone factor 7. Some places don't do that. I'm not sure if there's a proven benefit or not. And we'll do that unless they are accessible neurologically and or a liver is in the pipeline. Treatment of ICP, basically that is similar to neurosurgical patients. Very rarely we will go into mild to moderate hypothermia, and certainly there are lots of case reports of patients who've been kept cold for days and have survived to transplantation with good outcomes. But there's a concern with that and with barbiturate coma for infection in patients who are already at high risk. I've never seen anyone's liver removed. I'm told that we will do it, but that's if a transplant is likely to happen. Say there's a liver available for us in Perth, it's on its way and we just cannot control ICP, we will remove the liver. Our indications for transplantation are the same as King's College. However, there's debate that we should be re-looking at all of these. There are other ones. There's the French, the Clichy criteria, MELD score. None of them are perfect scores, and the hepatologist will sometimes look at a few other things. Take-home messages, early contact with the liver services if there are any, especially if there are red flags. Feed these patients. Don't correct coagulopathy. Don't avoid sodium, and watch the glucose, and there's no role for lactulose. Thank you very much.